Hello and welcome to the critically ill adult patient with pulmonary alterations. Let's take a look at some of these pulmonary alterations that we need to know about with our critically ill patients. First of all, critically ill patients have problems with ventilation, with perfusion, with diffusion in the lungs. So we're going to take a look at what some of these concepts are. This will give you some background information that you're going to need in order to be able to think about the critically ill patient who has a disease process. So, for example, to really be able to understand what's happening when a patient has ARDS or a pulmonary embolism or other critically ill pulmonary alteration, we need to know a little bit about some of this background information. So let's get started. Ventilation refers to the process of moving air in and out of the lung. Perfusion is talking about the actual blood flow. Okay, so that's a different kind of a situation that's happening. So ventilation is the air movement, perfusion is the blood flow. The third thing we have going on here is diffusion, and diffusion is referring to that gas moving across that alveolar capillary membrane, getting into the bloodstream, and actually binding up to the hemoglobin. So some different processes going on here, and each one of these may be altered or may not be, depending upon which situation is happening with our patient. Our critically ill patients have a lot of different alterations that can be seen by looking at a patient's arterial blood gas. And this is really the gold standard here, okay? A lot of times what happens is that we put our patient on a pulse ox when the patient comes up to the floor, the patient's having a crisis. Now, a pulse ox has a lot of problems with it. A pulse ox is a monitoring tool. It's not a diagnostic tool. If we really think that our patient has a pulmonary problem, they need an arterial blood gas. So we need to get that blood gas in the patient because it tells us so much more than we're going to find from the pulse ox. Now, the pulse ox has problems. One, it's peripheral. Two, it's going to measure everything that's bound to hemoglobin. That could also include carbon monoxide, nitric oxide, lots of other stuff, okay? And thirdly, it uses light in order to be able to read. And in fact, it uses a red light, which has the worst waveform of any light. And what will happen is that a lot of your ambient light, like the lights in the room, the light coming in from outside, all of those lights can interfere with that little red light on your pulse ox, giving you a poor reading. In addition, the patient's oxygen saturation is one of the last things to drop. So if we're watching the patient's pulse ox to try to give us an early warning sign that the patient has a problem, we're going to be misled, because what happens instead is that the pulse ox is going to be the last thing to drop. So some of the concepts we're going to talk about today include hypoxia, artificial airways, mechanical ventilation, and ventilator-associated pneumonia. Obviously, these are conditions that we see quite a bit of in an intensive care setting. So let's first do a little review of the normal physiology and function of our pulmonary system. The pulmonary system is influenced by a number of things, including, obviously, the integrity of the respiratory structures. So we have to have adequate airways. Our airways have to be open. They can't be all blocked up, or we can't have bronchospasm. In addition, we have to have an adequately functioning vascular system, so that has to be working correctly. We have to have the pulmonary musculature working correctly, and all of the other structures that surround the respiratory system. For example, we have the diaphragm down at the bottom, and if we have any problems with the abdomen, maybe the patient has intra-abdominal hypertension or they have an abdominal process going on, that can be pushing up into the diaphragm, and the diaphragm then cannot contract and drop like it's supposed to. So integrity of the respiratory structures is not just talking about the lung tissue itself, but the surrounding areas that can impact the lung tissue. Adequacy of our pulmonary circulatory system, that has to be working well. Remember that the pulmonary circulation is coming from the right side of the heart, it goes through the lungs, and then goes over to the left side of the heart. So if we have an inadequacy, if we have a problem with our pulmonary circulation, then blood is going to back up to the right side of the heart. Also, we have to have stimulation from the sympathetic and the parasympathetic systems. Now, these systems are going to do different things in the lung. The sympathetic nervous system is going to cause bronchodilation, whereas the parasympathetic system is going to cause bronchoconstriction. So it's kind of the opposite of what they do in the vasculature. In the vasculature, the sympathetic system is going to cause vasoconstriction, but in the lung, it actually opens up the airways, causing bronchodilation. Now, one of the time that it's important to recognize these concepts and to think about these concepts is in your patient as they go through their 24-hour day. So in other words, there's a difference in these different mechanisms. at different times of the day, and we call that a circadian rhythm. So there's a circadian rhythm to our sympathetic and parasympathetic activity. We're going to have our most sympathetic activity during the day, our most parasympathetic activity at night. In your patients who have respiratory problems, their best breathing is going to be at 3 o'clock in the afternoon, and this is due to that circadian rhythm. The worst breathing they will have is going to be at 3 o'clock in the morning, and again, this is due to the circadian rhythm, probably caused by some parasympathetic nervous system stimulation. Okay, another concept we need to know about here in order to be ready to take care of these patients is ventilation. Ventilation refers to the movement of the gases. So the ventilation is the air moving in and out of the lung. That's the ventilation part. Perfusion is a little bit different. So ventilation is going to be the gas movement, inhalation is active, and exhalation is passive. So in order to inhale, we have to contract the intercostal muscles and drop the diaphragm, contracting the diaphragm, in order to suck gas into or suck air into the lungs. Whereas exhalation is just simply the elastic recoil of the chest, allowing the lungs to collapse and the air to passively leave the lungs. So that's a passive process, whereas inhalation is the active process. So if your patient's struggling to breathe, in most cases it's going to be struggling to get air in because that's the most active process. Now, what happens is that gas moves in and out of the lungs, and we have ventilation because of a difference in pressure. This difference in pressure is created by the diaphragm dropping, chest wall expanding, which generates a vacuum. It generates suction so that we suck air into the lungs. So this is the way in which we are having our normal spontaneous ventilation. Perfusion, on the other hand, is referring to the blood flow through the pulmonary capillaries. Now, distribution of our blood flow in the lung is going to be influenced by gravity. Therefore, the bases in the back are going to have the highest distribution, the highest perfusion of any of the lungs. So when you're looking at your patient and you're trying to figure out, well, geez, what's the best part of the lung? What's the part of the lung that's going to have the best perfusion and be involved in the most gas exchange? Well, that's going to be the bases in the back. So an important assessment would be to listen to the bases in the back in your patient, because that's where the best perfusion is. Now, if you go around and you look in your patient's charts in clinical, what you're going to see is that a lot of patients have charted that they have diminished breath sounds in the bases. Okay, now, diminished breath sounds in the bases, that's not a normal finding. That's abnormal. So we would want to do something about that. Make sure that your charting reflects that you are doing something about correcting those diminished breath sounds in the bases. So patient encouraged to cough and deep breathe, or maybe the patient's on a ventilator. Okay, so we're turning and positioning, we're doing our suctioning, and what pulmonary interventions can you do for that patient to try to get those airways to open back up again, get rid of that atelectasis that's causing the diminished breath sounds in the bases? Because the best perfusion of the lung is the bases in the back, and so we want to make sure we're getting air to that area. Another thing that's going to cause a change in the distribution of perfusion is intraalveolar pressure. One time this is especially important is in your COPD patient. In your COPD who has air trapping is going to hyperdistend the alveolus, and then hyperdistended alveolus is going to compress the vasculature, increasing our intraalveolar pressure. That's going to decrease the distribution of perfusion to the alveoli because of that increase in pressure in the alveolus. Diffusion, on the other hand, is the third part in the process. The first part was the ventilation, so we had to get the oxygen into the alveolus. Now we're going to perfuse some blood flow around that alveolus. Now we have diffusion, where we have the gas exchange. So when we talk about diffusion, that's the gas exchange. The gas is being diffused across that alveolar capillary membrane into the blood, and it becomes dissolved as PO2 in the blood. So oxygen is moving across the alveolar capillary membrane, diffusing into the blood, and then CO2 has diffused from the blood back into the alveolus so that we can blow it off. Now, what's happening here is that we have a higher concentration of oxygen in the alveolus than we do in the pulmonary capillary, and that's what's causing our oxygen to move across this membrane. Same thing is true with the CO2. We have a higher concentration of CO2 in the pulmonary capillary than we do in the alveolus. That's what causes it to move out of the pulmonary capillary and into the alveolus so that we can remove it or blow it off. So what are some things that are going to influence diffusion. The driving pressure of the gases. So the greater the driving pressure, the greater the diffusion. So the higher the level of the PO2, the higher the level of the oxygen in the alveolus, the higher the PO2 will be, because the more gas will drive across that membrane. The thickness of the alveolar capillary membrane will also cause problems here. One of the major things that's going to cause a problem or a change in thickness of the alveolar capillary membrane will be fluid. Fluid starts to accumulate in the alveolar capillary membrane first, and then it moves into the alveolus. So your patient who has volume overload, for example, the patient has heart failure and has acute pulmonary edema, fluid moves into the alveolar capillary, or into the alveolar capillary membrane first before it moves into the alveolus. Now, the problem with having fluid in that alveolar capillary membrane is that you can't see it on your chest x-ray or on your pulse oximeter. You can't hear it when you listen to the patient's breath sounds, but the patient can feel it. And the patient hits a call out, you get down to the patient's room, and the patient says, I feel like I can't catch my breath. Okay, the respiratory rate's like 24, pulse ox is okay, the lungs are clear. See, what happens in those patients is we usually just assume that the patient is anxious, and so we're going to give the patient something for anxiety, when in fact the patient's already starting to develop some fluid in that alveolar capillary membrane. That's going to interfere with how well we have gas diffusing across that membrane. Now, another time that we can have problems with diffusion is when there is a change in the surface area of the alveolar capillary membrane. This happens in our patients who have COPD and have emphysema. Emphysema causes a breakdown in the alveolar capillary membrane, which will cause the patient then to have like one big alveolus instead of a whole bunch of little ones. This decreases the total surface area of alveolar capillary membrane that we have available to provide diffusion. Oxygenation is going to be another important component here in the respiratory system, obviously, and this is just a definition here for you, the addition of oxygen to the chemical substance or to a physical system. Now, what we're adding oxygen to in the patient is going to be into the bloodstream. First, it's going to enter the blood by way of diffusion. It's going to diffuse as a gas into the blood, and we'll have dissolved oxygen in the blood. That's called our PaO2. Next, the PaO2 is going to bind up to some hemoglobins and become SaO2. So SaO2 is the amount of saturated oxygen on hemoglobin. So our PaO2 is going to be one of the things that we're going to find on our arterial blood gas. So we have to send off a blood gas on our patient to get this. You don't get this from your pulse ox. And the PaO2 is the amount of oxygen that is dissolved in the blood. So it stands for the partial pressure of oxygen. Okay, but what it really is here is it's just the dissolved oxygen in the blood. Normal PaO2 is 80 to 100. Now, even though the number is 100, that's not 100%, and we can drive the PaO2 up higher if the patient is on supplemental oxygen. The SaO2, on the other hand, is the amount of oxygen that has bound to hemoglobin, and we call that oxygen saturation. So this is the amount of oxygen that has bound up to hemoglobin and is now going to be available to tissue. Now, the reason why we have to be worried about both of these values is that they can be different. They can be different based upon how well the PaO2 binds up to hemoglobin to become an SaO2. Now, why is the SaO2 so important? Well, because 97% of the oxygen that your tissues are going to use comes from the SaO2. So this is the oxygen saturation is the part that's really important to the tissues. So this is the part we have to make sure that the patient is getting. Now, the second bullet point on your screen here says this is a value obtained by pulse oximetry. Not really true. SaO2 is the value that we get from our blood gas. What we get from the pulse oximeter is the SpO2. Okay, so an SpO2 is an estimate of the SaO2. All right, now let me tell you why this is different. Because pulse oximetry is a peripheral way of measuring, and it's also done outside of the patient's body. It's not direct, it's indirect, and we use light in order to do that. Well, first of all, the problem with having it be peripheral is that we would like to have a central measurement of our patient's oxygenation. Well, that's not going to happen because we're measuring way out there on the fingertip. Next, if the patient has peripheral arterial disease or any kind of peripheral vascular disease, the patient's going to probably have an altered pulse oximeter reading. The pulse oximeter also uses light waves, and in fact it uses red light, which is the worst waveform of light that there is, because any other kind of light is going to interfere with red light. So red light is bouncing off the hemoglobin and telling us how much stuff is bound to hemoglobin. So the red light can be a problem, and if you're having a hard time getting a pulse ox on a patient, take their hand and stick it underneath the covers. What you're going to find is getting it out of the light, because ambient light in the room or light coming in from outside can interfere with your pulse ox. So stick their finger underneath the covers, and a lot of times you're going to get a pulse ox where you couldn't get one before. Now the third problem with the pulse ox is that it measures everything bound to hemoglobin. So that includes oxygen, nitric oxide, carbon monoxide, anything that's bound to hemoglobin gets measured as being part of your pulse ox. So it can be a little inaccurate. Now the thing about pulse oximetry is that pulse oximetry is a good monitoring tool. It's not a diagnostic tool, it's a monitoring tool. So it's like our cardiac patient who comes into the hospital complaining of chest pain. We want a 12-lead EKG on that patient. Okay, once we have the 12-lead EKG, then we can go back and we can take a look at our patient by way of telemetry to monitor the patient. But we need the 12-lead because that's going to tell us what's really going on with our patient. Now the SaO2 tells us about how much oxygen is actually saturated to our hemoglobin molecule. Probably the most important thing to take out of this slide here is the fact that we can have an oxygen saturation of 100%, but if the patient's hemoglobin level is low, that doesn't mean the patient's oxygenating well. Okay, so what it tells us, the SaO2 tells us how much of these binding sites have been bound up by oxygen. 100% of the sites could be bound up, but if the patient's hemoglobin is only 5, then there's not enough hemoglobin to carry oxygen molecules. So even though the hemoglobin of 5 has 100% of those sites bound, that's not going to be as good a gas exchange as if we had 100% oxygen saturation with a hemoglobin level of 12. Okay, so anemia could affect how well the patient's oxygenating beyond what we see in our SaO2. Now there is a relationship between our PaO2 and our SaO2. Remember, the PaO2 is the amount of dissolved oxygen in the blood. So this is just telling us how much oxygen got dissolved in the blood. What we want to know is how much of that dissolved oxygen got bound to hemoglobin. And again, the reason why this is important is because the tissues are using the SaO2. There are some things that will interfere with how well PaO2 binds up to hemoglobin to become SaO2. The relationship between these two factors is what we call the oxyhemoglobin dissociation curve. The oxyhemoglobin dissociation curve is going to represent the relationship or the affinity of oxygen to hemoglobin. So then the oxyhemoglobin dissociation curve relates to our SaO2 and our PaO2, and what it's going to do is it's going to tell us how well our hemoglobin is going to bind up that oxygen. And there are some things that are going to interfere with or that are going to have an effect on how well oxygen binds to hemoglobin. Okay, so here is our oxyhemoglobin dissociation curve, and what we're showing here is a normal curve, and then we're showing a shift to the left and a shift to the right. Now, the three main things that are going to affect our oxyhemoglobin dissociation curve and cause it to shift to the left or the right are going to be pH, CO2, and temperature. Okay, we're going to come back to that. We're going to talk more about those. But let's just take a look at what the curve is and how this curve is going to work. So the curve in the middle here, the B curve, that's the one that I'm looking at here, the blue one. Okay, now the B curve is the normal curve. And let's take a look at, say, a normal PO2. So our patient has a normal PO2. Remember, normal PO2 is 80 to 100. Let's pick right in the middle there and say our patient has a PO2 of 90. Okay, now follow this 90 from the bottom. See, the PO2 goes across the bottom. The oxygen saturation goes across the left side. And what, again, our oxyhemoglobin dissociation curve is telling us is there is a relationship to our PO2 to our oxygen saturation. So take a look. Our PO2 down here of 90, follow that line up, follow it up, follow it up, follow it up, and I'm thinking that we're right about here on our blue line, right? Okay, now follow that line over to the left, and I'm thinking we're right about here on our oxygen saturation, if I followed it over correctly, okay? So we have about a 95% oxygen saturation, between 90 and 100 over on the left side there, from a PO2 of 90. Okay, So that's what our oxyhemoglobin dissociation curve is telling us, is there's a relationship between the PO2 and the oxygen saturation. When everything's normal, then our PO2 of 90 is going to give us an oxygen saturation of 95%. Okay, let's jump down a little bit here. Let's go down to 80. All right, so now we're going to have a PO2 of 80. Let's go up, and let's see where we are at on our curve. Okay, so with a PO2 of 80, we're about right here on our curve. And so maybe we went down maybe 1 or 2. We didn't go down very far. So follow that over here, and we've got an oxygen saturation of about, let's say, 94% now. So with a PO2 of 90, we had an oxygen saturation of 95. With a PO2 of 80, we jumped all the way down to like 94. Not a big difference, right? Okay, let's take a look at this curve, though. You see how we're at the top of the curve when our PO2s are normal. So in the normal range of PO2, we're at that top of the curve where it's flattened out. Let's take a look further down. Let's say that our patient has a PO2 of 40. Okay, now follow that up, and let's see, our PO2 is, I think I'm right about here on the blue line. So now follow that over, and we're going to see now that we have a oxygen saturation of about 75%. Okay, not very good, right? All right, now let's just go down to 30. Okay, now remember, we jumped from 90 down to 80 with very little difference. Let's jump down to 30 and see what happens here. See if we have very little difference again. I'm right by the B, I think, if I follow this up correctly. Now follow that over to the left. Follow that line over to the left, and I'm about at 60 now. Okay, so with a PO2 of 40, I have a 75% oxygen saturation. With PO2 of 30, I'm down to 60% oxygen saturation. Wow, can you see that big jump downward? Here, at the top part of the scale, I jumped only down about 1 or 2 points when I had a 10-point drop in the PO2. You get on that slippery slope, though, and we hit a PO2 of 40, we're at 75, PO2 of 30, we're at 60. So can you see that when we hit this downward slope here, we're going to drop our PO2. Our PO2 is going to drop the oxygen saturation very quickly. Now, a couple things we can gather from that. One is that as the PO2 drops, our oxygen saturation is going to drop, and it drops pretty quickly once we get outside of the normal range. The second thing we can get from looking at this diagram is the fact that the PO2 is going to change a lot before the oxygen saturation drops. This is why it's important, again, that we're getting the information from our blood gas. The oxygen saturation, their SpO2 that you're getting from your pulse ox, is not going to change much until we hit the slippery slope and we start running down that slippery slope. And by that point in time, your patient's crashing. Guys, you can see it from the diagram right here, that what's going to happen is as your patient starts to decompensate, as your patient starts to have this respiratory problem, we don't see the change in the pulse ox until the patient is on that slippery slope running downhill. Okay, let's take a look at shifts in the left and the right and see what happens with these different shifts. Okay, so here is our diagram again, and the distortion you see in the diagram is just because of the way that the picture printed up on the screen here, so it doesn't represent a different curve. Here's our normal curve in the middle again, here's our B curve. Let's go down here to the bottom. Now this is a shift to the right. This happens when a patient has a change in their pH. For example, they become acidotic, they have a high CO2, or they have an increase in temperature, they become febrile. Now we're going to start with a 80 PO2. So run that 80 PO2 up to the blue line here, and again, we're probably right about here on that blue line, and we run that over, and on this diagram here, it looks like our PO2 is going to be right about 95% off that PO2 of 80. Okay, so pretty good with our normal curve. Now, what happens, though, when we get a shift to the right? Our patient is acidotic. Maybe it's a COPD, or he has a high CO2 causing a respiratory acidosis. All right, well, what happens is that we're going to have a shift in the way that hemoglobin binds oxygen. And in fact, our hemoglobin molecules will not bind oxygen as readily as they do when we have a normal pH. So let's take a look at this. With our PO2 of 80 on the bottom there, we run that back up. Now we're looking at the purple line, letter C, over to the right here. Letter C is showing that shift to the right. Okay, so we're looking at this line here. Now we're about here on our line. So let's follow that over to the right. Follow this over to the right, and I think I'm right about here on the scale. Okay, Okay, so here, the only thing that happened is we have the same PO2. The PO2 is exactly the same. It's 80. What happened is the patient became acidotic, and that acidosis is going to interfere with how well oxygen binds to hemoglobin. So our curve is shifting to the right, and then we see that what's going to happen is that our oxygen saturation is going to go down. So we had a drop in our oxygen saturation all because of that change in pH. And we're down here to like 88% now. We were at 95% with our oxygen saturation when we had a normal pH, but just dropping the pH or just increasing the CO2 or just increasing the temperature can cause this patient to drop their oxygen saturation. Now, what does this mean? Well, first of all, it means that the hemoglobin is not as likely to want to bind oxygen in the first place. And then it's more likely to want to let it go. So these are the three factors that are going to result in the patient having a shift to the left or the right. We're going to have a change in pH, a change in CO2, or a change in body temperature. The shift to the right, again, is caused by the acidosis, the increase in CO2, or the fever. It causes a rightward shift in our curve, which is going to make the hemoglobin not have the same kind of affinity or not have the same kind of attraction to oxygen. So oxygen is not going to bind as well to hemoglobin. Now, the other side of the coin is that because oxygen does not bind as well to hemoglobin, oxygen will be more readily released at the tissues. This is a protective mechanism in the body to try to protect the patient from having a situation where they have acidosis. For example, the patient is in shock. The patient has developed hypovolemic shock, so the body's going to react. We have a low pH because we slip into anaerobic metabolism. The pH becomes low. Now, hemoglobin is going to be more readily releasing oxygen at the tissue level to try to maintain those tissues. So it's kind of a protective mechanism that we see in the body. So here's our three charts again. We have our shift to the left and shift to the right. Now, let's talk a little bit here then about a shift to the left. Now, the shift to the left would be like our A. We have a little different view here. But we had B was our normal one, so A is our shift to the left. Let's start out again with the same PO2 we had before, 80. Run that PO2 up to the normal line here, letter B. Run that B over. So we're going to try and take this over sideways here, and we'd have a PO or oxygen saturation of about 95%. Now, let's take it on the A line, which is going to be our shift to the left. Okay, 80%, or 80 PO2, run that up. So we run that up here, and now we're on the top line, so we're way up here, okay? Now we run that over, and we're at, whoa, we're even higher. We're at like 98% oxygen saturation. Boy, that sounds like a good thing, doesn't it? The problem is what's happening now with a shift to the left is that hemoglobin's getting kind of greedy. Hemoglobin binds oxygen better, but it doesn't let it go. This happens when your patient has a high pH, or in other words, the patient is alkalotic, or the patient has a low CO2, or the patient has a decrease in temperature. So hemoglobin becomes greedy and it binds up oxygen better. This can lead to tissue hypoxemia because the hemoglobin's not releasing it. So even though it looks good, you're looking at the patient saying, well, look, you know, his oxygen saturation is really good. It's 98%, but it's not being released at the tissue. So then here is our kind of summary page here where we have the shift to the left caused by an increase in our pH, making the patient alkalotic, or a decrease in the CO2, or a decrease in temperature. Our right shift causing by a decrease in pH, in other words, the patient's acidotic, an increase in PCO2, or an increase in temperature. Okay, now obviously the oxyhemoglobin dissociation curve is just talking about the hemoglobin that we have present. So the more hemoglobin we have, the more oxygen will be bound to hemoglobin, so we'll have more oxygen in the blood. But on the other hand, okay, your patient may have anemia, and that the patient can have a normal PO2, a normal SaO2, but still have a low oxygen content because they don't have enough circulating hemoglobin to take that oxygen to the tissues where it needs to go. One of the other things we need to talk about here in relationship to our critically ill patient is the arterial blood gas. And again, this is going to be the definitive diagnostic test. We want to be able to look at our arterial blood gas to give us a good idea as to what's happening with our patient. Just putting on that pulse ox is not enough. Pulse oximetry is a monitoring tool. If we think our patient's having a respiratory problem, they need the blood gas. Okay, now this is talking here about a 5-step analysis. I have the 6 Easy Steps to ABG analysis on Vista for you. That's probably going to be a lot easier to understand than just a real brief rundown here. But what we want to do is we want to assess the PaO2, the pH, the CO2, and the bicarb, looking for whether or not the patient is acidotic or alkalotic, and then matching them up. So matching up the CO2 or the bicarb with the pH in order to be able to figure out if it's a metabolic or respiratory thing that's causing the problem. Okay, so let's take a look at some of these values and what they mean. First, the normal blood gas, our PaO2, is going to be between 80 and 100. The normal value is age dependent though, so in our elderly population you could expect to see values that are maybe less than 80, and that's okay. Okay, you got somebody who comes in who's 95 years old and has a PO2 of 70, we're not going to treat it, okay? Unless there's some kind of acute physiology going on in our patient. But in general, we're not going to treat it. We're going to assume that that's normal for them. So it is age dependent. It is going to decrease with age because our patient is losing functional units of the lung. As you age, you start to lose alveoli, and our elderly patient's going to have fewer alveoli than the younger patient would. A critical value would be determined as being 40. Now, hopefully you're going to know about this before you get a PaO2 back on your blood gas of 40. Hopefully you're going to know that the patient's got problems from their other lab values going off and screaming like crazy and everything else. But this requires immediate action. In fact, this patient needs to be intubated like right now. The pH, the normal, is 7.35 to 7.45. So you see there's a tight little range there right around 7.4. If the pH is less than 7.35, it would indicate acidosis. Greater than 7.45 indicates alkalosis. Try to get out of the sloppy habit of talking about blood gases in terms of high and lows. You'll hear people all the time telling you that the patient has a low pH. Try to get out of that habit because that gets confusing. All the values don't go the same way. So when we talk about high and low, what's going to end up happening is somebody's going to get confused here because they don't all go the same way. So we need to start talking in terms of acidotic, alkalotic, acidosis, alkalosis, because that's the thing that we're going to be seeing with our patient. So talk in terms of acidosis. Next, let's look at the PaCO2. Now, the CO2, those normal values, between 35 and 45, you might be able to remember this easily by remembering it's the last two numbers of the pH. So pH 7.35, 7.45, CO2 is 35 to 45, okay? So, that might be one way to remember it. This is the respiratory component of the acid-base balance. If we were to have an acidotic CO2 and an acidotic pH, our patient would have a respiratory acidosis, okay? And if the CO2 is greater than 45, that would indicate an acidosis. If the CO2 is less than 35, that indicates an alkalosis. Now, here is where the CO2 gets confusing. You may have noticed that a low pH was acidotic, a high pH was alkalotic. Well, here you're noticing that the CO2 does the opposite thing. A high CO2 is acidotic, a low CO2 is alkalotic. This is why we can't talk in terms of highs and lows. What we need to talk about instead is we need to talk about acidotic or alkalotic. So a high CO2 is going to be acidotic, and this is caused by alveolar hypoventilation. In other words, the patient is not able to blow off the CO2. A CO2 of less than 35 is caused by alveolar hyperventilation. Your patient's hyperventilating, blowing off too much CO2. This could be a compensatory mechanism for metabolic acidosis. Okay, in other words, ventilation is measured by looking at the patient's CO2. So when we're looking at our patient's function, remember again, we had ventilation and then we had perfusion. Okay, ventilation is going to be marked on our blood gas by the CO2. Oxygenation or perfusion is going to be marked by our PO2 and our O2 saturation. So if the CO2 is too high, that means the patient's not moving enough air. Your patient who has a high CO2, like your COPD, is not moving enough air. Now, they may be gasping for breath, but air is not moving in and out of their lungs because they have bronchoconstriction and they have airway damage. Okay, so if the CO2 is too low, that means your patient's moving too much air. They're hyperventilating. So we need to slow down their breathing. Another component that we see on our arterial blood gas is the bicarb. Now, the normal bicarb is 22 to 26. If the value is less than 22, the patient's acidotic. Greater than 26, the patient is alkalotic. Now, the bicarb refers to the metabolic component of our acid-base balance. So it's referring to the metabolic piece. The CO2 is referring to the respiratory piece, so the bicarb is referring to the metabolic piece. Now, the metabolic system involves an awful lot of different things. Okay, so it's not just referring to the kidneys. A lot of times you're going to hear people talk about the bicarb referring to the kidneys. Well, yes, it does. But the bicarb also reflects the acid-base imbalance caused by any other metabolic problem in the body. For example, a patient could have a metabolic alkalosis caused by vomiting. So we're losing fluid from the upper GI tract, read, stomach. Okay, so the patient is vomiting, and they're vomiting up acid from the stomach, which results in a loss of acid, and the patient becomes alkalotic. On the other hand, we could have an acidosis caused by a variety of different things. Lactic acidosis caused by shock or things like that. Renal failure can cause a metabolic acidosis. Diarrhea, okay, the opposite thing that we're having from the stomach. And then lastly, a ketoacidosis from diabetic ketoacidosis. So a lot of things can cause a metabolic acidosis. So when we look at our patient's pH, we're going to determine whether it's acidotic or alkalotic, and then we're going to try to figure out which one of the two systems is involved. We do that by matching it up. In other words, if the pH was acidotic and the CO2 is acidotic, that means the patient has a respiratory acidosis. If the pH was acidotic and the bicarb was acidotic, it would indicate that the patient has a metabolic acidosis. Now, if the other value, for example, let's say that our patient has a acidotic CO2 and an acidotic pH, so we have a respiratory acidosis, and the bicarb was alkalotic, that would indicate compensation. Okay, now the body wants to try to compensate. We don't like to have a pH imbalance in the blood, so the body's going to try to compensate and do something about that imbalance. When we talk about compensation, what we're talking about is the body's ability to be able to try to get the pH back to normal. So the body's going to try to do that. It's always the opposite system that's doing the compensation. So for example, if the patient has a metabolic acidosis, then it's going to be the respiratory system that's involved in compensation. And the respiratory system is going to try to get the pH back to normal because we want to have a normal pH. If we are successful in getting the pH back into the normal range, then we call that full compensation. If we are not able to get the pH back into the normal range, we call that partial compensation. And if the opposite system is not trying at all to compensate, that's called uncompensated. So what can we do about it? Oxygenation problems are fixed by increasing the availability of oxygen. Now, again, that might mean doing your turning, positioning, your incentive spirometry, all those good pulmonary hygiene kind of things. It can also mean giving the patient some supplemental oxygen, or by helping oxygen diffuse across the alveolar capillary membrane. Okay, and again, we're going to do that by getting our patient's fluid away from that alveolar capillary membrane. So then hypoxia is caused by insufficient levels of oxygen in the blood. Okay, so that's our definition of hypoxia. Obviously, this is a problem that we see, and quite frequently actually, in the intensive care unit. Either the patient came to us with hypoxia or developed hypoxia because of their underlying condition, and we need to treat it. So what we're going to have to do is first to be able to identify it in our patient. Mild to moderate hypoxia is going to cause the patient to have tachypnea and mild hypertension. So again, if you're working on the floor and your patient is starting to develop a respiratory problem, anticipate that first of all, the respiratory rate is going to go up. The patient's going to have tachypnea. And that's the body's mechanism to try to compensate here and to try to get more oxygen into the blood. We're going to get some mild hypertension and peripheral vasoconstriction. These are the result of the sympathetic nervous system. Now, it may sound kind of counterintuitive here, the fact that the vasoconstriction is starting to occur, because that's actually going to decrease our peripheral vascular blood flow by having vasoconstriction. But this is part of the sympathetic nervous system. The sympathetic nervous system sees this hypoxia as being decreased tissue perfusion, and it's trying to increase cardiac output by activating the sympathetic nervous system. So it doesn't know the difference, and unfortunately it's going to probably cause us more problems than it's going to help. Mild changes in intellectual function with headache, restlessness, and fatigue. Remember again that the first thing that changes in your patient's mental status is going to be behavior. So as we start decreasing the amount of blood flow to the brain, the amount of oxygen to the brain, the first thing that changes is behavior. Severe hypoxia, now the patient's going to be hyperventilating. They are going to be gasping for breath, have dyspnea, cyanosis. In the early stages, they're going to have tachycardia, followed by bradycardia and or dysrhythmias. In the late stages, the patient is going to have that bradycardia, dysrhythmia thing happening because they are decompensating. In the early stages, the patient may also have hypertension caused by the sympathetic nervous system, followed by hypotension, somnolence, and loss of coordination as that patient decompensates. So as the hypoxia starts to take over, the tissues no longer are responding, and the patient becomes hypotensive. The patient has somnolence and loss of coordination. So we need to get an airway in this patient. We're going to pop in an artificial airway, and the first type is called our endotracheal tube. So this is a picture here of our endotracheal tube. Now, in clinical, you probably don't see this whole thing outside the patient's body. What you're seeing is probably just this top piece out here that's sticking outside of the patient's body. All right, well, now we got the rest of this going back into the patient's mouth and going down the patient's trachea and sitting in the trachea. Now, about this part down here is sitting in the patient's trachea past the vocal cords. So we've got our vocal cords sitting about here-ish. And so this part is sitting in the trachea, and then we have an airway into the patient's trachea. Now the balloon is inflated down here, so you see we have a balloon down here, and that balloon is inflated, and I actually made my trachea kind of big because the balloon should be touching the walls of the trachea. Now the reason for this is so that we can push air down the tube and air just doesn't leak back out. It goes down into the lungs, and we can even use some pressure on this to get the air down into the patient's lungs. So that's the reason why we have the balloon. Now, one of the problems with the balloon is, of course, secretions are going to come from the upper airway here, and they're going to ride right down this tube. And they're going to park themselves right above that balloon, and they're going to start to bunch up here above that balloon. The other thing we're going to have is that balloon is inflated to the point where we have a minimal cuff leak. What this means is that when the patient has that full breath of air, when we give that breath of air into the patient by the ventilator, then what's going to happen is at the very end of that breath, there's going to be a little bit of air that's going to sneak back past that balloon. Now, the reason why we want to have that minimal cuff leak there is because that tells us that the balloon is not inflated too much. If we inflate it too much, it's going to press on the walls of the trachea and actually cause necrosis. So that's not a good thing, so we have a minimal cuff leak. Now, the bad part about that minimal cuff leak is that every time we inflate that patient's lungs, every time we give that patient a breath, there's a little bit of a cuff leak, which can allow this gross stuff, remember this secretion that's building up here, to come back down around that tube and down into the lungs and infect the patient. So every time you suction the patient, when you stick your suction catheter down that endotracheal tube, you suction your patient. When you get done, take your suction catheter, stick it down the back of the mouth here, and get down here and suck that stuff out of there. You know, if you ever turn a patient and stuff rolls out of that patient's mouth, you know there's secretion sitting in the back of this pharynx here that we need to get out because they're going to work their way down, migrate down past that endotracheal tube into the patient's lungs, and we're going to have a mess. Now, other airways we may use in a patient, this is a trach. A trach is like an endotracheal tube, except it's much smaller, and it goes in through the patient's throat here. So it's going to go in the front of the neck, and it's going to sit into the trachea. And the purpose of a trach is for long-term ventilatory work on our patient. Some of the same kind of things that you saw before. We have our balloon again, like we did on the endotracheal tube. So that's going to blow up in the trachea. Again, it's going to have a little more minimal cuff leak, and here we have the inflation tube and the spring-loaded valve. So this thing here, we're going to inflate, put our syringe on here, and push air into that, which is then going to be shooting air into our cuff. Okay, so we got air in a cuff. The cuff is inflated. Now you're going to go down and suction this patient. Keep in mind that this thing, I mean, this picture here is a pretty good representation of what it looks like. It's only about 4 or 5 inches long. It's not very long. Okay, so if you're used to suctioning patients' endotracheal tubes and you come and suction one of these, you're going to be surprised because you stick that catheter down here and you're going to be out of the end of this thing and hitting the carina in no time at all. So anticipate you're only going to have to stick that suction catheter down about 5 inches here before you hit the carina, the patient coughs, and now you start pulling that suction catheter back out and doing your suction. Also pictured here is the inner cannula. The inner cannula goes inside of this device. So the inner cannula goes in there, and we take the inner cannula out to wash it and replace it as needed. Okay, so that's the inner cannula piece. Also pictured here is our arbitrator, and this thing here goes inside that trach when we need to put it in. So when the surgeon comes in and puts this thing in the first place, you may notice that around the edge of this thing looks like it could be a little bit kind of sharp, and we may have a problem in our trachea if we just ram that thing in there. So what they do is they take this arbitrator and they stick it inside the trach. They actually stick it in the top of the trach. It goes down through the trach, and it's going to come out the end. Now, you notice this rounded end on that arbitrator there? That rounded end is going to stick out at the end of this tube here, and it's going to provide a rounded mechanism so that we can slide it on down the trachea, and it's not going to cause any damage. As soon as that's in place, you just pop this arbitrator out, and you usually tape it up to the wall or stick it somewhere near the bedside in case the patient pulls it out so that we can replace it. Okay, now we have our airway in and we need to ventilate our patient. So we are going to start our mechanical ventilation in our patient. The goal of mechanical ventilation is to get the patient off of it. So this is our number one goal. When we intubate somebody and put them on a ventilator, our goal is to get them off the ventilator. So some of the interventions that we're going to use here to try to get that patient off the ventilator is we're going to have really good pulmonary care for our patient, and we're going to start that weaning process early. The goals of mechanical ventilation are improve ventilation, improve oxygenation in our patient, maybe to correct an inadequate breathing pattern, and decrease the work of breathing that our patient has to do. So our patient may be really struggling and using up a lot of energy that way. So what we'd want to do is to try to decrease that work of breathing for our patient, make it easier for them. Now, to manage mechanical ventilation on your patients, what we need to do is to just talk a little bit about what some of these different things mean. You're going to hear people tossing around these terms all over the place, so let's talk about what they mean so that you have a better feel for what we're doing with our patients. Some of this common terminology you hear as referenced to ventilators includes tidal volume, respiratory rate, the FiO2, which stands for the fraction of inspired oxygen, the mode. And we're going to hear people talk about different kinds of modes that your patient is on. PEEP, which stands for positive end expiratory pressure, and then pressure support. Let's take a look at each one of these in a little bit more detail. First of all is the tidal volume. The tidal volume is the amount of volume that your patient is going to be getting with each breath. Now, what we do when we're giving a patient a tidal volume is we're not removing all the air from the lung and replacing it. So it's not like you're blowing up a balloon and then letting it go and letting it deflate. Instead, what we're doing is we're cycling and we're turning over air that is sitting in the lung. Yes, there is going to be some movement of the chest up and down. The lungs are going to inflate and deflate, but they don't deflate totally. There's still some air that's left in the lung. Your tidal volume is just the amount of air that is circulating in and out of the lung to try to maintain oxygenation. Now, tidal volumes have been traditionally or conventionally, we would use a tidal volume somewhere in the range of like 10 to 12 mLs per kilogram. And the newer thinking is that we ought to be using a lower tidal volume so we cause less damage to the lung. This is called a lung protective strategy. And in a lung protective strategy, we go down as low as 5 or 6 milliliters per kilogram. So what's shown on your screen here is 6 to 8 milliliters per kilogram. So in other words, if your patient was a 70 kilogram patient, okay, so your patient's a 70 kilogram patient, then we would have a tidal volume of 420 to 480 milliliters that's going to be dialed into the ventilator. Now, the actual amount of tidal volume that the patient gets is going to be displayed and recorded by the ventilator. So with each breath, there might be a little bit of a difference between one breath and the next as to how much tidal volume your patient gets, depending on whether or not the patient allows the ventilator to give them the full breath. The next thing that we're going to talk about is respiratory rate. Now, the respiratory rate is both going to be defined by and monitored by the ventilator. So in other words, the ventilator will be set for a specific rate. We may tell the ventilator to give 10 breaths per minute. Now, the patient can breathe faster than that 10 breaths a minute. So there's going to be two different rates that you're going to read off of the ventilator. You're going to read the set rate, which will be that 10 breaths per minute, and then you'll read the respiratory rate, which might be 18. The patient could be breathing quite a few more breaths than the 10 breaths per minute if the patient feels like they need more oxygen or if they're anxious. The next component we're concerned about is the fraction of inspired oxygen, the FiO2. Now, what this simply means is the amount of oxygen in the air. The air that you're breathing right now, room air, is 21% oxygen. So our FiO2 would be 21%. When you put your patient on a 40% venti mask, that's 40% FiO2. When we put somebody on the ventilator and we hook them up and we put them on 100% FiO2, that means the patient's getting 100% oxygen. So the only gas they're getting by that endotracheal tube is going to be oxygen, straight 100% oxygen. Now, if we were to dial that down to 50%, that means the patient's getting 50% oxygen and 50% air, and other gases that are in the air. Assist control is one of the modes we use on our ventilator. Assist control is a mode that is going to support every breath that the patient takes. So there's two ways that the ventilator can work. It can work by supporting every breath. And let's back up for a minute and talk about every breath. There's two types of breaths your patient can take. The first type is going to be the machine-initiated breath. The second type is going to be the ventilator-initiated breath. The machine-initiated breath is what the ventilator is set to deliver. So, for example, if I set this ventilator to deliver 10 breaths per minute, that is the machine-initiated breath, 10 breaths per minute. Now, above that, your patient can breathe faster if they want to. So my patient's breathing at a rate of 18, 10 breaths are being delivered by the ventilator, and 8 breaths are being initiated by the patient. In assist control, the ventilator is going to kick in, and it's going to deliver all of the breaths. So all 18 breaths get the full preset tidal volume in assist control. Now, one of the advantages of using assist control is that it kind of lets the patient rest a little bit because they don't have to do any of the work. So this is often an initial mode of delivery after the patient has been intubated. So your patient comes to you and the patient has respiratory failure and we need to have an initial mode of delivery of oxygen to the patient. Oftentimes it's going to be assist control because it allows the patient to rest. Especially if your patient needs to have a significant amount of sedation, we would want assist control because assist control is going to guarantee the patient gets those breaths. The other modality we can use is called SIMV. SIMV stands for Synchronized Intermittent Mandatory Ventilation. You may also hear this referred to as IMV, the patient's on IMV or the patient's on SIMV. It means the same thing. All IMV, Intermittent Mandatory Ventilation, is synchronized. Synchronized means it's just not going to give the patient a breath when the patient's trying to exhale. Okay? So it's synchronized with the patient's own respiratory efforts. Now what happens in SIMV is that the ventilator only delivers the breaths that are ventilator breaths. In other words, if we set the ventilator for 10 breaths a minute, the ventilator is going to only deliver 10 breaths a minute. If your patient breathes at a rate of 18, the ventilator does not deliver those additional 8 breaths like it did in assist control. Now the patient's going to have to draw those breaths in himself. So the ventilator would deliver the 10 and the patient would have to actually breathe in the extra 8 all by themselves. So that's the difference between assist control and SIMV. Assist control is going to support every breath, machine-initiated and spontaneous. SIMV is only going to support the machine-initiated breaths. The spontaneous breaths will have to be what the patient can draw in by themselves. An advantage of SIMV is that it helps to keep the respiratory muscles active. The patient has to keep breathing on their own. We're supporting some of the breaths, but the patient's taking some breaths on their own. So they are doing a little bit of the work. As the patient improves, you can just lower the rate. So we may have started the rate at 10. We lower it to 8, to 6, to 4, to 2. You can lower the rate actually to 0.5, which means the patient gets 1 breath every 2 minutes. Now, if the ventilator is only delivering 1 breath every 2 minutes, the patient can be extubated. So this is one method of weaning the patient from the ventilator. In addition, we can add pressure support to IMV. Pressure support is going to give the patient a little bit of positive pressure during inspiration. A little bit of positive pressure during inspiration. And what this is it's like walking downhill. It's easier to walk downhill than it is to walk uphill, right? Same kind of thing is true when we put a patient on pressure support. Pressure support supplies a little bit of pressure during inspiration, so it makes it easier for that patient to take the breath. So as that patient starts to inhale, the ventilator just kicks in. It's not giving a breath, but it's simply just helping the patient a little bit to take a breath, decreasing the work of breathing a little bit. Now, that's not necessary during assist control because the ventilator does all the work in assist control. But in SIMV, now the patient is having to do some of the work themselves. So pressure support will be helpful in getting that patient to take those adequate breaths. An additional modality we can add to either assist control or to IMV is PEEP. PEEP is positive and expiratory pressure. What it does is it allows the alveoli to stay inflated at the end of expiration. Okay, now think about this like a balloon. So we blow up a balloon and you release the balloon and what happens? Right, the balloon deflates and collapses. Well, the same kind of thing could happen in a lung. So what we do is rather than you blow up the balloon and then you pinch off the balloon before it can completely deflate. That's like what PEEP does. PEEP is some positive pressure at the end of expiration. Think about what that means. Patient takes a breath in, then they exhale, air is leaving the lungs, the alveoli are likely to collapse, so we provide some positive pressure. It's like pinching off the balloon and keeps those alveoli open. So PEEP is going to increase the amount of air we have in the alveolus and therefore the amount of oxygen we have in the alveolus, and it will increase the patient's oxygenation. Now, we have some alternatives to mechanical ventilation as well. So we can also use CPAP or BiPAP. CPAP is the same thing as PEEP. It's continuous positive airway pressure. It does the same thing as PEEP does. It helps to hold the alveoli open and keep them from collapsing. So CPAP is going to improve your patient's oxygenation. BiPAP is CPAP plus an inspiratory pressure to decrease the work of breathing. So BiPAP, because it also has an inspiratory pressure, which decreases the work of breathing, is going to make it easier for your patient to take a breath in. Therefore, he's going to move more air, and it's also going to help to remove CO2. So CPAP improves oxygenation, BiPAP improves oxygenation, and helps to remove CO2. This is a patient here who is on BiPAP. So this is a BiPAP mask. This mask is just going simply over the nose. They make masks that will go over the nose and the mouth too. This mask is just simply going over the nose. Now what happens is that the BiPAP machine is giving both that end expiratory pressure and an inspiratory pressure. Oftentimes you'll see these used in patients in the hospital who have sleep apnea. But we can use BiPAP as a rescue method for patients who have an acute illness. In fact, BiPAP has been shown to decrease complications and mortality in patients who have an exacerbation of COPD or acute pulmonary edema caused by cardiogenic heart failure. So the patient who has heart failure and has cardiogenic pulmonary edema, or the patient who has an exacerbation to COPD, both those patients can benefit from BiPAP therapy. And we simply put that BiPAP mask on the patient's nose, or the nose and mouth, depending on the mask you have. Kind of crank it on down there so we get a tight seal, and it's going to provide both an expiratory pressure and an inspiratory pressure for our patient. Now, some complications associated with mechanical ventilation, and believe me, this is just a partial list, is we can have damage caused to the airway from intubation. So we can have mucosal damage, structural damage in the mouth, the pharynx, or in the trachea caused by intubation. Self-extubation is a complication, especially when we get to the point where we're trying to wean that person from the ventilator. Oftentimes what happens is we lighten up our sedation to the point where the patient is now awake and doesn't like the way that tube feels, and he reaches up up and grabs that tube and yanks it out. Now, we would prefer to lower the pressure in the balloon before we pull that tube out. In addition, of course, we want to have extubation be a monitored event, and that's going to be monitored by the respiratory therapist, by the nurse, and maybe even by the physician. So we want to have a monitored event occur here, so we don't want any self-extubation. Let's leave this to the professionals, okay? If your patient does self-extubate, you want to get all over that respiratory assessment and be with that patient for at least the first 15 minutes to make sure that they're not going to have any complications. About 25% of your patients who yank their own tube are going to need to be re-intubated. Cardiovascular impairment can also ensue due to increased intrathoracic pressure from mechanical ventilation. So the ventilator, when we're giving the patient a breath, not only increases the pressure in the lungs, it also increases the pressure in the mediastinum. We're compressing the mediastinum, which decreases venous return to the heart, causing changes in your patient's hemodynamics. Now, that might be a good thing if your patient has heart failure and you're trying to decrease the patient's preload coming back to the heart. But if your patient has decreased cardiac output, decreasing this or causing cardiovascular impairment could cause the patient to have decreased cardiac output and the blood pressure may drop. When you intubate a patient, always watch the blood pressure, because chances are the blood pressure is going to drop, caused by this increase in intrathoracic pressure, decreasing venous return to the heart, and causing a decrease in cardiac output. Watch for a positive fluid balance. Okay, mechanical ventilation can cause a pulmonary SIADH, which means that the pulmonary system is releasing antidiuretic hormone, telling the patient to hang on to fluid. So watch for this. The patient could develop a positive fluid balance. Infection is also a complication. Ventilator-associated pneumonia, very prevalent here, and we want to try to prevent the patient from developing a ventilator-associated or hospital-acquired pneumonia. Lastly, long-term ventilator dependence. Of course, we don't put anybody on the ventilator expecting they're going to take the ventilator home with them, all right? So the first priority when we put somebody on the ventilator is let's get them off. In order to make sure that our patient is going to be compliant with mechanical ventilation and not pull out their tubes and things like that, we may have to use some restraint. Mechanical restraints such as soft wrist restraints may be necessary. Chemical restraints are widely used, including Ativan, Versed, Diprivan, just ask Michael Jackson, fentanyl, etc. Okay, so those things are types of chemical restraints that are going to help the patient to be able to relax. Those are sedatives that we're using during mechanical ventilation. Now, they work differently. So you may have patients on multiple drugs. For example, you may have the patient on an Ativan drip and a fentanyl drip. Ativan is a sedation kind of a medication, whereas fentanyl is a narcotic, and it's going to help with pain that the patient may be having. Most patients relate mechanical ventilation as being moderately painful. Remember, they have a tube down their throat, and it's forcing air into their lungs. That's a little bit different than the normal method we have of breathing, and this can be very uncomfortable for the patient. The first two drugs, the Ativan and the Versed, are benzodiazepams, and it may be helpful to use those medications in your patient. They can cause a situational amnesia that may be helpful or desired if your patient has a rocky ICU stay. I don't think anybody really wants to remember all the poking and prodding and everything else that happens while they're in the ICU. So that's a kind of an added benefit that we get from those drugs. The drugs are going to be titrated to desired sedation level, and there are sedation scores that are used in the intensive care unit. The RASS is one. There's a number of other ones that are also used to help to provide us with a objective feel for what the patient's sedation level is. Now, in some patients, we may not be able to just sedate them enough by using our other medications like Ativan, Versed, Diprivan, etc. We may actually have to, they still may be fighting the ventilator. We may have to use too much of those kind of drugs in order to get the patient sedated. So in those cases, we may also have to use a neuromuscular blocking agent. So these medications are neuromuscular blocking agents, and basically what they do is they paralyze the patient. The patient is paralyzed. Okay, now the patient is paralyzed, which means that the muscles are not working, but everything else is working. Now, when you give this drug to the patient is going to look like they're unconscious. They are not. Okay, they can't respond because they have no function of their skeletal muscle systems, okay? So there's no functioning there going on the skeletal muscle system. One thing right off the bat you're going to have to do is you're going to have to make sure the patient has an airway, and we have a way to ventilate the patient, because neuromuscular blocking agents paralyze the patient, and they paralyze the respiratory musculature. So this patient will stop breathing as soon as that medication is given, which might be a good thing if the patient is ventilated. If the patient's on a ventilator and they're fighting the ventilator, this might be a good method to use. However, we're going to have to use other drugs in addition. You may have to put the patient on some fentanyl. You may have to put the patient on some Ativan. The patient may need some sedation in addition to the paralytic. Don't ever use a paralytic just by itself. Okay, because what's going to happen is that patient underneath that paralytic is alert and oriented, and they can't move. I can't think of a more distressing situation than being alert and oriented and being unable to move your body at all. They would suffer all of the pain and all of the other discomfort that would come from laying in bed without being able to move, from having a tube down their throat and being suctioned, and everything else that goes along with being a critical care patient. But the only thing is they just can't move. They're totally paralyzed, yet they have to feel all this and be totally alert and oriented. In order to make sure that our neuromuscular agent is doing enough, but not too much, we're going to use a train of 4 stimulator, and the train of 4 stimulator is placed on the patient's forearm in the path of the ulnar nerve. And then what we're going to do is this little device here just provides electrical shock. And what it's going to do is to stimulate the nerve, causing muscle spasm. So we're going to be looking for muscle spasm, and we're going to increase our intensity of our medication in order to make sure that the patient is not getting too much of a spasm caused by the train of 4. So what we're trying to do is we're trying to get a nice kind of a balance here so that the patient is not getting too much drug, and yet, on the other hand, we are giving enough paralytic to cause the patient to not be fighting the ventilator. Medical and nursing interventions, we need to monitor the heart rate, the SaO2 closely, and our patient is mechanically ventilated. Prevent ulcers, turning and repositioning every 2 hours, really important here. The patient can't turn themselves. If we can't turn in position because the patient's hemodynamically unstable, then we need to put the patient on a rotational bed. Nutrition is important when not contraindicated. Our patient in the hospital is going to very quickly start to lose their albumin level. Albumin is manufactured by protein that we take in our diet. If we're not getting protein in the diet, then the patient is not getting an adequate nutrition, and that's going to cause a lot of problems with our patient, not only with fluid balance, but also with maintaining calcium levels. Intestinal stimulants like Regulin may be necessary. Remember, we're giving this patient medications like fentanyl and Ativan and Versed. We're slowing down the GI tract, so we may have to give something to speed it back up a little bit so that we can feed the patient. Also, prophylaxis such as Pepsid or our proton pump inhibitors such as omeprazole and some of those other drugs are going to be helpful as well. Keep in mind that when we give these drugs that are going to decrease the amount of stomach acid, the opposite side of that coin is that it increases the risk the patient's going to have infections, because now we've made the stomach a better place for that bacteria to live. Which brings us to one of the infections that patients get when they're on a ventilator, and that is ventilator-associated pneumonia. Now, ventilator-associated pneumonia is a type of hospital-acquired pneumonia, and the Centers for Medicare and Medicaid have decided now they're no longer going to reimburse for a hospital-acquired pneumonia, and as such, we should also be aware that ventilator-associated pneumonia is also going to be placed on that list. Well, the Centers for Medicare and Medicaid see hospital-acquired pneumonia and ventilator-associated pneumonia as being a reasonably preventable illness. Oh, okay. Well, what can we do to prevent it? We'll get there in a minute. Let's take a look at our risk factors. Okay, risk factors, critical illness. Well, when you look at this stuff, this is like every patient in the ICU, isn't it? Okay, so our patients are at risk. Now, they have these clusters of care for preventing ventilator-associated pneumonia. The cluster of care is like a care plan. It's a multidisciplinary care plan that we can use to help us to be able to implement certain interventions that are going to help to decrease the risk of our patient developing ventilator-associated pneumonia. So first of all, we're going to attempt our weaning process early. And usually we start weaning immediately. As soon as that patient is intubated, we start the weaning process. What that means is that we start weaning down our FiO2. We start thinking about decreasing our amount of sedation as soon as that patient's hemodynamically stable so that we can start weaning the patient off the ventilator. We don't like to let people lay around resting on the ventilator for days and days at a time. As soon as they're stable, we start trying to get it off. Employ rotational beds, especially if the patient can't turn. Your patient, you turn them, they become hemodynamically unstable, get them on a rotational bed, because what that'll do is it helps to mobilize secretions. Keep the head of the bed at 30 degrees to try to prevent microaspirations from the gut. Oral care needs to be at least 2 hours, and toothbrushing, well, the general recommendation is every 12 hours. Okay, with intubated patients, we may want to kick that up to every 8 hours or even every 4 hours. Now, the thing about toothbrushing is it's going to remove the plaque on the teeth. And the plaque on the teeth is where the bacteria lives that migrates down the trachea and gets into the lungs. So toothbrushing is going to be important here. Now, if your patient is on a ventilator and is intubated, you don't need to lather them up. Don't think you have to get going here with all the toothpaste and water and everything else. Okay, don't drown the patient here. What you need just simply is your toothbrush and your Yankauer suction, and just manually use the toothbrush in the mouth there to break the plaque off the teeth. Maintain proper endotracheal tube cuff pressure so that we're trying to prevent having some of those secretions run down around the outside of the cuff, and suction above that cuff by sticking your suction catheter down the back of the patient's throat after you've suctioned the endotracheal tube. Now, a lot of times we're using those inline suction catheters. If you're using one of those, you may have to take a separate suction catheter to get down the back of the patient's throat. Just getting the Yankauer into the back of the throat may not be enough for some patients. Okay, now weaning. Obviously, this is the goal of mechanical ventilation. We put the patient on the ventilator. We want to get the patient off. So there's a number of things here that can interfere with the patient being weaned from the ventilator. The amount of oxygen that the patient is currently requiring. So we need to wean that down before we can start weaning the process. The respiratory rate. We're not going to start weaning if the patient has a respiratory rate of 36. The patient has to have an adequate neuromuscular status. Their mental status has to be adequate. We want to check their fluid volume status and make sure they're not volume overloaded. Check their acid-base status too, and their fever, nutritional status, electrolytes, and look to see whether or not they have anemia. Now, the patient can tolerate having a couple of these things be abnormal if we optimize the other things and if we're aware in the weaning process that we have that abnormality. But certainly we would want to optimize as many of these things as possible so that we could have the best success at weaning. Our weaning criteria is that the patient must have a respiratory rate less than 30, and they must have a vital capacity between 10 and 16 milliliters per kilogram. Let's take a look at that. Okay, this chart here is illustrating a patient's vital capacity. So now what the chart is showing here across the middle is our tidal volume. So what we're seeing is our tidal volume in our patient here. And that's that tiny little thing going across the middle. Here we go. Here, this is our tidal volume. So this nice little in and out volume going across the middle here is a tidal volume. Now the tidal volume, the function of tidal volume in the body is simply to circulate the air. So when you look below that tidal volume, you're going to see there's a whole bunch of air that is in this lung. This air is called the functional residual capacity, and this is the air that's in the lung that is providing the gas exchange. Notice that the tidal volume is not impacting that, other than it's going to circulate the air that's there. Okay, now to give you a better idea as to what this means. Okay, right now, today, as I'm taping this, it's about 88 degrees outside, so certainly I've got the air conditioning on. And as the air conditioning kicks on, it doesn't suck all the air out of the room and then replace it. Instead, what happens is it's going to circulate the air that's already there. That's what your tidal volume is doing. Your tidal volume is circulating the functional residual capacity so that we have oxygen continuously available at the alveolus. Now, if you were to take a deep breath in, you're going to get this maximal inspiratory reserve. So that's our inspiratory reserve. Blow all the air out of your lungs, and you're going to get this expiratory reserve we see over here. Now, if we were to take those two and the tidal volume together, so we're going to take those three pieces together. So we're taking this and this and this all together. That's our vital capacity. Okay, so that's the thing we're looking at that we want to be between 10 and 16 milliliters per kilogram. In addition, we also want to check our patient's minute volume. Now, the minute volume is the amount of volume that the patient is breathing in and out. So the tidal volume is multiplied by the patient's respiratory rate, and we have to have an adequate amount of minute volume. Now, your respiratory therapist is going to do this, by the way. So they're going to order weaning parameters on your patient, and this is one of the parameters that the respiratory therapist is going to figure out, is the minute volume. But we need to have the minute volume be adequate for the patient. In other words, this means the patient is moving an adequate amount of volume, an adequate amount of air to be able to maintain respiration. Lastly, we need to have a negative inspiratory force that is greater than -2 centimeters of water. So we want to have a negative inspiratory. Now, we're talking about a negative pressure here, so this might be a little bit confusing. So having a negative inspiratory force greater than -20 would mean that we have a negative inspiratory force, for example, of -30. Okay, so I don't know. It gets kind of confusing when we're talking about less than and greater than and negatives. But we want to have a number that's greater than 20. Okay, how about that? In our negative inspiratory force. Now, what negative inspiratory force is referring to is the amount of negative pressure, vacuum, suction, that the patient is able to generate when the patient takes a breath in. So in other words, take a deep breath in right now. Just kind of, okay, suck that air in. Okay, that's your negative inspiratory force. Now, the way we figure this out is that on the end of that patient's endotracheal tube, we're going to stick a little device on there, a little dial, and then as the patient takes a breath in, okay, it's going to obstruct their endotracheal tube. This device obstructs their endotracheal tube, so the patient is struggling to try to breathe in, and they're going to try, develop that negative inspiratory force. They're going to try and suck in air, and they're not going to be able to because we're blocking their airway. But what it's going to do is it's going to generate that negative inspiratory force. Now, if the patient has a very weak inspiratory force, that'll be reflected by a negative inspiratory force that's a number less than 20, and we may not want to extubate the patient having that weak of a respiratory musculature. All right, now hopefully the patient has done well. We got the patient extubated, and now we're going to take care of the patient post-extubation. This is an important time that you're at the patient's bedside. About the first 10 to 15 minutes, make sure you are at that patient's bedside post-extubation because that's when most problems occur. Remember again, about 25% of your patients who get extubated are going to need to be re-intubated. So suction, cough, deep breathe, do all the good pulmonary hygiene. Anticipate your patient's going to be working some stuff up. They're breathing differently now than they were when they had the tube in. And because of that, they may be working some stuff up. They may be having a little bit of initial difficulty that they get over. Watch for laryngeal edema. The fact that we had that tube in the back of the patient's mouth, the fact that we had that cuff inflated in the trachea could cause the patient to develop laryngeal edema. So how will you know? All right, listen with your stethoscope over the trachea, and we're listening for a stridor. A stridor is a high-pitched inspiratory sound. High-pitched sound on inspiration. That's called a stridor. You can hear it by listening over the trachea with your stethoscope. Sedate the patient with care. Okay, now this patient does not have an airway anymore, so we need to be careful. We don't want to over-sedate the patient where they lose their airway. So we would be sedating this patient like we might sedate a patient who's on the med-surg floor. Keep them MPO for a while just to make sure we don't need to re-intubate, and then we're going to have frequent respiratory assessments to make sure that this patient is maintaining. Well, that's it for this segment on critically ill adult patients with pulmonary alterations. Hopefully, some of this background information will help you as we start to talk about the pulmonary problems that our patients can exhibit, and we talk about that in class. Please remember again also to use the 6 easy steps to ABG analysis. I think that's going to help you a lot with your blood gases. There are going to be blood gas interpretations on the exam. All right, thanks for joining me, and until next time, this is David Woodruff. Bye now.